A very good afternoon to you all. Today I am here to discuss regarding few conditions which can result in pathological hearing loss. So before going to the conditions, I would like to discuss about the ear anatomy a little bit. The ear is actually divided into external ear, which consists of ear pinna, the external auditory canal, and the outer part of the eardrum. And the middle ear consists of the inner part of the eardrum, ear ossicles, till the round window. And inner ear consists of the semicircular canals, vestibule, cochlea, and the origin of the auditory nerve. So today we'll be discussing about these conditions. First and foremost about secretory otitis media, which is also known as otitis media with effusion or glue ear. So 80% of the children will be having at least one episode of otitis media with effusion by the age of 3, and 40% of the children have a history of at least 3 episodes of otitis media effusion. So it is a very common thing, but the problem is that most of the times it is a missed diagnosis. So usually it happens, the commonest cause for otitis media with effusion is it starts with a acute otitis media episode, and the persistence of recurrent upper respiratory tract infections and frequent infections can result in the persistence of this otitis media with effusion. And in most of the kids there will be around 30 decibel hearing loss when there is this condition, but most of the times it's not detected. So whenever children are coming to you with recurrent upper respiratory tract infection, you have to ask them regarding all these findings, all this history. I mean, is there any associated hearing loss, or are the children increasing the TV volume while they are watching the TV alone, or is there any delay in speech and language development, or is there any features of inattention, is there are they having poor social behavior, or are they finding it difficult to participate in group activities. All these things are pointing towards the fact that the child is having some sort of hearing loss. So kindly evaluate it. You should make a point that you are examining. As pediatricians, I am advising you, please check their ears. If you are finding something, please refer it to the ENT specialist. We can treat it. Okay, and one more thing I would like to focus is that sometimes we have a general belief that the adenoids means they are the tonsil-like tissue which is located in the nasopharynx, that is behind the nose. So only if there is a physical obstruction, when there is complete blockage of the nasopharynx because of the adenoids, then only it has to be removed. No, it's not like that. Even if it is not causing that much physical obstruction, if there is a biofilm infection of the adenoids, it can result in persistent and recurrent upper respiratory tract infections, and it can also result in persistent otitis media with effusion. So it has to be removed, and it can cause better results in children. So whenever a child is coming to you with recurrent nasal block and discharge, who is not able to sleep properly, who is twisting and turning in the bed, getting up in between because of breathing difficulty, who is watching TV in a higher volume, who is sometimes not very energetic, they are to be evaluated to rule out this condition and to rule out adenoids. Next is chronic otitis media. This is basically a chronic inflammation of the middle ear and mastoid cavity, which will be presenting with ear discharge through a eardrum perforation. So usually it will be associated with a hearing loss also. And in children who are having conditions like Down syndrome, craniofacial syndromes, Dijot syndrome or microtia, they can have an increased incidence of chronic otitis media. Next is otosclerosis. This condition usually presents with progressive hearing loss, more common in females, and usually this condition aggravates during pregnancy and puberty. and most of the times you can get a positive family history also, because this runs in families. Next is sudden onset sensory neural hearing loss. So this patients typically present with a complaint of hearing loss, like when he got up in the morning, he is not able to hear from one side. This is the most common history that patients will give. Otherwise, they can also present with blocked ear, sometimes ringing sound in the ear, tinnitus. So, as per definition, sudden onset SNHL is a decrease in the hearing loss of at least 30 decibel in 3 contiguous frequencies occurring within a period of 72 hours or less. So, this is an otological emergency. It can be caused because of multiple etiologies, but the most common cause is idiopathic, and mostly it presents as unilateral thing. This thing can be treated if diagnosed on time. Next is ototoxicity. So as doctors, we'll be dealing with drugs every day, but we have to understand the fact that the sensory epithelia of the inner ear of birds and non-mammalian vertebrates can regenerate, but in mammals, humans, the inner ear hair cells of cochlea cannot regenerate. So once some damage happens to that, it will not regenerate. So these are the drugs which can cause ototoxicity. Some drugs can cause temporary hearing loss. So such drugs, if we are withdrawing, the hearing loss will be reversible. But drugs like aminoglycosides, cisplatin and organic solvents can cause permanent hearing loss because of the death of hair cells. And antibiotics like streptomycin and gentamicin are vestibular toxic. These are the common drugs which can cause ototoxicity. And aminoglycosides can cause both cochlear toxicity and vestibular toxicity, and mostly this symptoms will be manifested only after a few days or weeks after the parenteral treatment. But even with a single topical application of this antibiotic drops can cause damage, and some people are genetically predisposed to aminoglycoside toxicity. So while prescribing these medicines, we have to keep all these things in our mind and do it as per the patient's advantage. And 80% of the patients taking anti-tubercular therapy for TB will end up with ototoxic side effects. Next is barotrauma. Barotrauma occurs after flight travel, scuba diving, free diving, roller coaster rides or hyperbaric therapy. Usually patients will present with pain on descent, or associated hearing loss or vertigo. This can also be treated. Next is presbyacusis or age-related hearing loss. They usually present with a progressive bilateral sensorineural hearing loss in mid to late onset, and it occurs because of the age-related changes happening in cochlea. And when a patient is coming with hearing loss in an elderly age group, first we have to evaluate to rule out other causes, because this is a diagnosis of exclusion. So this is the scenario happening in a patient who is having presbyacusis. So as per statistics, 30% of the 60th decade individuals are having this presbyacusis. So basically they will be having problems like they will not be able to catch particular words, they will not be having clarity, and some patients can have tinnitus and they'll be using louder TV volume. And as the age progresses, there will be an abnormal growth in the perception of loudness also. So in elderly, there is no point in shouting to them. It will again make them more disturbed, socially isolate, and they will go into depression. So this can also be treated with a hearing aid. So I'm ending with the famous words by Helen Keller: blindness separates us from things, but deafness separates us from people. So let's all hold our hands together and let's make hearing care for all, and let's make it a reality. Thank you.